We've had a nice opportunity to hear from our speakers here this afternoon, and what I'd like to do is take this time now to open it up to questions from the audience. Certainly, if you do have questions, since we're streaming this live, it would be great if you could use the microphone that's along the aisles there, and then we'll go ahead and see what kind of nice conversation we can have surrounding the low-impact instrumentation and the intelligent flow system of AirSeal. I have a question over here.
Yes, I have a question. There is 3 ways to have enough abdominal space to work in. It's the pressure, the Trendelenburg, and the anesthesia. So my question is, what was your degree of Trendelenburg, and what was anesthesia? Was it with deep block, paralysis of the abdomen, or was it the usual way of just intubation with the rocuronium and continue without it?
I can start first. So we would actually also do local anesthesia, right? I would max out my 0.5% marking. And I don't know the actual degree, but I just asked them for the actual bed limit of how far the Trendelenburg can go. And in terms of if you're looking to decrease nausea and vomiting in our patients, because our patients are usually young female, the primary they want to use is IV propofol. So that's so this is predominantly using IV propofol to induce general anesthesia.
What was the degree of the Trendelenburg?
I don't know the degree, but I can go back and measure and get back to you.
We just use enough Trendelenburg to get the bowel out of the cul-de-sac.
Yeah.
But you should.
And it varies.
And it's
Just like the pressures vary to get adequate visualization. I'm sure whatever's happening on the other side of the anesthesia sheet varies too.
it's true that it's like
Okay, thank you.
it's like a deal with the anesthetist that when we lower the pressure, they are okay to accentuate the Trendelenburg. So it's like a deal we are doing with the anesthetist.
Yeah, and I usually ask just enough, I say, can I get a little more Trendelenburg? And then when I'm done, and I know I'm done in that area and I don't need as much, I'll turn it down a little bit and kind of just play with the Trendelenburg and ask anesthesia how is the patient, and try to use the minimum amount needed to get the job done.
Yeah, I mean, I think that just from the experience of utilizing, in particular, the AirSeal system in surgery, I am a big advocate for not placing the patient in full Trendelenburg at the outset, because I think that there's enough literature to support that there are implications for that. I think we can gain a lot of benefit by combining that with variations in the pressure that we use and variations in the Trendelenburg that we have to really try to gain as much as we can for the patient, because certainly if the cases are a little lengthier and the anesthesiologists end up having to work a little harder on some of these patients who are maybe heavier or have comorbidities, I think it's nice to try to see if in your practice you can strike a balance between how much Trendelenburg you need, as Michael said, in terms of just when you see what you need to see, set the table and then vary the insufflation pressures, and I think there's a lot that could be gained by that approach as well. Another question from the audience.
A couple of comments. First, Dr. Wang, I noticed the average BMI on your case was 26. I would pay patients if they could come to me with a BMI.
You can come to New York. So we actually looked at the higher BMI. I think maybe, if I can remember correctly, about 35 of our patients, and roughly a third of our patients have BMI over 30. So we are continuing to follow that out, just because we think the respiratory parameters obviously should be more beneficial in more obese patients.
And another comment, in the early 90s, I was using an instrument called a Lapro Lift by Origin, and the anesthesia loved it. I don't know if anybody in the audience from Japan, that's where this all started, where you're basically operating in an atmospheric environment. I wish we had the 3mm instruments at that time. The patients did extremely well. I'm sure they'd do that much better with the small instruments.
So you can extrapolate from the low pressures to zero pressure.
Right. Well, I always now drop the pressure down to 6 to make sure there's hemostasis, and I
Yeah.
find I'm seeing pretty well. I just have never taken it to that level to operate. With robotics, you can't make the adjustments.
Right.
Only now the XI has come out with a table where you can adjust it while you're
Right.
operating.
But that's another cost that your hospital may or may not want to spend on.
Yeah, but I have been using the AirSeal since it came out, and it's amazing.
Yeah.
I won't work without it.
Great. Given, before we take the next question, I will comment that, something that's always interesting that I've observed that it's also striking a balance is, when we do lower the pressures, and certainly when you drop the pressures below 8, that's below venous the pressures, so you're certainly going to pick up on bleeding. But the other thing that I've always noticed is how much more bounding the vessels are in the pelvis when you drop the pressures down. So the one caution I would always say is as you push the envelope to drop the pressures is to balance that with the type of surgery that you're doing. And if it's a case where you're really navigating the retroperitoneum and doing a complex dissection, that sometimes there's value in actually having the pressure a little bit higher just to minimize that sort of back and forth bellows that you see when you're operating, and that kind of will minimize the risk of potentially getting into to any kind of major vessel.
Yeah.
But just an observation. Another question from the audience.
Actually, I guess, can you hear me?
Yes.
I guess you have just answered my question right now, because my question is dealing with hysterectomy for BRCA patient, very straightforward, or overall, I'm talking about more advanced case, like stage 4 endo or stuff like that you're dealing for more dissection. I really like higher pressure on those kind of case because it works as a tamponade, and I don't want to cauterize around the ureter, for example. I want to leave them alone, and the tamponade effect of pressure 99% of the time is enough unless something is pumping. The other aspect of using high pressure is even again on the advanced case when there's lots of adhesion, using pressure to open up the third space like pararectal space. I just want to know what's your input about this kind of case. Do you guys have any experience with using low pressure on this type of?
I kind of just use 10 for everything. So once we went, so again, I think you could do it stepwise. I mean, I think you have very valid concerns, as I did. So that's why I went to 12 first and then went to 10. So we don't actually pick and choose our cases. We just have it on 10 for everything. And if we somehow can't see well, like if you have a 3,000 gram uterus and you just can't see around, then every once in a while we'll bump it up to 12, but actually we've never bumped it above 12. But again, you can feel it out. You can try to go to 13, 12 and see how you feel, and then keep going. But in stage 4 endo cases, I have not found that I needed a higher pressure. It's usually when I have a small patient with a small abdomen and they're actually really skinny and then have a huge specimen and I just really have trouble seeing around it. That's when I will actually bump it to 12, but that's my experience.
And, when I've operated at lower pressures, I kind of think of it as like a bicycle tire. Like you fill up a tire and eventually it has enough distension to keep its shape. But when you push it down, it kind of gives a little bit. The higher the pressure you go, you don't expand that tire bigger. It stays, pretty much at one particular shape. It's just you get more resistance. So when I enter with trocars, I'll go at a higher pressure, and then once I bring it down lower, it kind of collapses a little bit, but for the most part, you just kind of get a little bit more give in the abdominal wall and the tissues everywhere else when you are operating, with the breathing. But it hasn't even really been an issue so much for me, but I'm only doing it at 12 instead of 10, so.
I think I'm gonna go to 8 now. It sounds like we're gonna but at the end of the procedure, I will decrease the pressure to 5 because I think that's my lowest setting. And then I will look at the cuff and at my myos, or if you're stage 4 endo cases, all of them, right before we start closing, we'll decrease the pressure to 5 and just kind of let it sit for a minute or two and see if there's any bleeding. So I think that's an important thing to do.
Our team performed the retroperitoneal lobo-aortic
Dissection?
lymphadenectomy with 8 millimeter. So it's possible. Because when you are in the retroperitoneal space, when you put the stable pneumoperitoneum with 8, they perform the
same.
lymphadenectomy safely.
But the pneumoperitoneum depends on the patients.
That's what.
And you can decrease the pressure. And you must try with your machine. Which machine? But you must try with your machine to decrease the pressure, and you see it's possible to operate the patient at 7 millimeter with AirSeal. It's sure. It's really sure.
You know, I think the important take-home point here is it's a dynamic process, right? And so depending on the clinical scenario, you know, I think you need to be able to be flexible about the variation. And I totally appreciate the last gentleman's question, because I think that there are times where you utilize the slightly higher pressures to create or at least establish an ability to get better countertraction on adhesions, or you use the pressures to open up spaces. A lot of us do that, and we follow where the pneumoperitoneum dissects. And so I think the key here is, whereas before individuals were very static with their use of insufflation, I think with the technologies that we have today, particularly those that are by ConMed, it allows us to really vary the pressures while you're performing surgery, and I think that's an important piece to keep in mind, particularly when it comes to managing the more complex cases. I do have a question for the panel, really, in general here, and one of the things I noticed, you know, it's always tough to appreciate that in studies, but particularly as it relates to the low-impact instrumentation, really looks that it can deal with much tougher tissue, because I noticed you utilizing it on you know, advanced endometriosis cases. Have you found that to be the case, that it's durable?
So when I first used this, I didn't even notice that it was, you know, a 3 millimeter diameter. When you compare it to a 5 millimeter instrument, it's robust, it's strong, it's got good grip strength, and the tips aren't shorter. It's the same length as a 5. If you look at some other, I guess, 3 millimeter instrument lines, they've decreased the diameter of the shaft, but they also decreased the length of the tip. So they've made everything miniature, even the tip, which makes it not as usable. For this, the low impact line, you know, I really like how it's a smaller diameter, but the tip length is still the same as a 5 millimeter. So in that aspect, I don't notice a difference, and it works just as well. It has the same grip strength, and the shaft is robust enough to do everything that I need in just a regular instrument.
Yeah, you know, it often seems to be a criticism of 3 millimeter instrumentation, that it's not going to be durable enough. But certainly, I'm one of those seeing is believing individuals. Just watching your videos, it really kind of made me realize that those instruments are quite durable to be able to complete, you know, cases where the tissue is going to be a lot tougher. Question from the audience?
Yeah. Hi, Neeraj Mehra from Vancouver. I've had the fortune of using the AirSeal, and I was particularly curious about the comments with respect to improvement in pain scores. And so I just use the AirSeal, but use straight stick laparoscopy of 5 millimeter instruments. And I'm curious to know how much of the benefit in pain is related to the AirSeal with the reduced pressure operation versus the 3 millimeter instruments. And did you notice a difference perhaps using the AirSeal alone and 5 millimeter instruments going down to 3 millimeters?
So, you know, I'm working on pain studies looking at the use of robotics compared to traditional 5 millimeter laparoscopic instruments, and comparing it to instrumentation of 3 millimeters or less. Right off the bat, and modifications to the pain medication regimen I'm constantly tinkering with to try and perfect that painless hysterectomy thing of mine. Right away, I see that robotics and traditional laparoscopy for me all had, you know, similar pain scores for the 23 hours that they stay. But when I switched to a 3 millimeter diameter instrument and the low impact line, the pain scores dropped immediately. And you know, when you're looking at pain scores and pain tolerance, pain levels in patients, it's really hard because everybody has different, you know, pain scores. I have a 10, and it's really not that bad. So pain score is a bit, hard to measure, but all of my patients, when I use low impact instrumentation and 3 millimeter instruments, has a sharp decrease to about 3 within the first 12 hours. And, the 5 millimeters and the traditional laparoscopics and robotics kind of all hovered around 6 for 23 hours.
I would say that you can extrapolate from the cases where people would use the 12, 12, 10, 12, and then dropping down to 5, 5, 5, and you see a significant decrease in pain, and you can kind of go from there and say, well, if you can reduce it by another factor 4, then you would expect the pain to be less as well. And in fact, in my patients, and I'm allowed to do this because I'm not in a study or doing a research trial, it's been significant enough that I use the smallest incisions, the fewest incisions, and I use the higher tech CO2 insufflation whenever possible.
Yes, and 3 millimeter, there is no stages. It's more simple.
I think what's important to appreciate here is, in a time where we're all looking at enhanced recovery around surgery or ERAS, it's all about bundles, right? And so, as you hear from all the surgeons up here, it's not just one thing that they're doing. They're doing a series of things that collectively have a significant impact on the patient's recovery. So, you can already see that running low pressures is beneficial when you have the opportunity to do that. If you add on top of that smaller instrumentation, another added benefit, and then of course just a lot of the counseling preoperatively, the management of the medicinal protocols, both pre, intra, and post-op, using local anesthetics on the incisions. All of these things really additively have a huge impact as a bundle for enhanced recovery around surgery. And what's exciting is certainly everybody up here sharing their experience with utilizing two pieces of that puzzle that make up a bigger picture in terms of what we can do. Any other questions from the audience? Any final thoughts from the panelists?
We talked about Trendelenburg and incision size and using the minimum amount of intra-abdominal pressure to achieve, our goal. It all kind of falls in line with the whole philosophy of minimally invasive surgery,
For people that have undergone,
we try to use the minimum amount of incisions, the lowest impact to patients to get the job done. And, it has better outcomes. So less incisions, smaller incisions, less intra-abdominal pressure. And I think that's what the whole minimally invasive surgery field is about. And this low impact line is
We got
perfect
45 years of accumulated knowledge base.
Yeah.
Thank you to our senior people who brought the original ideas to us.
Yeah, with the 45th anniversary of the AAGL, it's very timely. Well, I think with that, I think we're going to go ahead and end. I want to go ahead and thank again CONMED for sponsoring this excellent conversation on minimally invasive surgery and low impact laparoscopy. And to you, the viewers online, as well as those here in attendance, and of course to our wonderful panelists here. Again, thank you very much.
for people that have undergone surgery and have had to take weeks off and have had all kinds of discomfort and bleeding and scars and pain, that if they could have done it this way, I can't imagine why everybody wouldn't do it. And maybe it's because the surgeon doesn't do it, or maybe because it's new. Obviously, I didn't know, so you don't know where science is at with all of their stuff. You just hope that the doctor that you've got is doing the most current and best thing. And I don't know, I just want to believe that everybody's doing that, but it was easy.